1800s. And the only difference is they're, maybe the ones we have here are a little bit newer. But basically, it's a little curved thing so it can slide in, and there's the curve to help out. You should never be using these because you get in trouble. We also have these things called meatal dilators. Remember we talked about the guy with the real tight stricture at the meatus. You just pop that in, that'll, stretch things out a little bit. You put a little KY jelly on it, lubricate it, stretches that area. And then the best thing for us are the scopes. It's a little tough to bring up here. We have to bring the water bag, we have to bring the light source, but we can look in with a little telescope, get it in. Once we have it in, we can put a wire, take the telescope out, and we can pass a catheter that has a hole on it, that's called a counsel tip catheter, over the wire, and it pops it right in. So that's for really difficult things. And ideally, every catheter we couldn't get in, if we could do it that way, that would be great, because then we'd have less problems. But again, it's tough to bring that up, and it costs money, and it's expensive. And big bladders, I think 4 liters is the biggest bladder I've ever had. This guy's one of the guys, we had 4 liters in his bladder. That's pretty big. Suprapubic tubes. Now sometimes we can't get things from below, so we put a little tube that goes in from here to here. It's a suprapubic tube, and all it does, it goes through the skin. You have your rectus muscle, you have fat, and then you have the bladder. And they're really easy to put in if the guy is really distended. If he has a 4-liter bladder, boom, you just pop them in and they go right in. If the bladder's not distended, you can miss, you can hurt things. So we have to make sure the bladder's distended when we use suprapubic tubes. And again, we have a little kit that has a needle. The needle goes in and then the little thing goes over. And we always put it about 2 finger breadths above the pubis. When the bladder's really distended, we pop it in. And when you go to change these things, I don't think you guys are allowed to here. A lot of places you are. It's a pretty simple thing. You just take the balloon down, you take it out, you put it in, and you have to push it in all the way so that it hubs in. This is one where you definitely want to push in. And then once you're in, you blow the balloon, you get the fluid back. Now on these kind of people, usually they're going to be empty, so you're not going to get fluid back. So if you blow the balloon up, these are the ones that you pull back, and you'll feel the balloon kind of settle in against the bladder right here, and you'll go, okay, that's where it is. So again, suprapubic tubes, full bladder, 2 finger breadths above the pubis, and we pop straight in. We do them in the OR. We usually cheat by putting a scope in, filling up the bladder, and looking as it goes in, so we can be more precise. And finally, we see a lot of robots, Da Vinci robots being done here. And everybody always says, well, how did we end up with the Da Vinci name for a Da Vinci robot? Well, it's kind of interesting. Da Vinci, it's a little company out of Intuitive Surgical out of Sunnydale, California, up in Silicon Valley, and they have the Da Vinci robot. And so how does Da Vinci get to California? Well, Da Vinci was a famous Renaissance painter, and in 1504 he painted the Mona Lisa. That's his real famous painting. And back in 1500 when they did the Mona Lisa, that was the best painting ever, biggest painting, most famous thing. And so the model Mona Lisa became very famous. And where do famous people end up? They all end up in Southern California. So she came to Southern California, and so that's how we got the Da Vinci name, from the Mona Lisa from Da Vinci, and she's in Southern California. So, for summary, a couple of things. I gave you sheets here. If you don't have them, make sure you get one. There's a couple of things that are important. Make sure the patient's in a position of comfort for you and for the patient. Make sure you have good exposure, have good light, exposure of fat, exposure of the foreskin, push things back. Realize that women will have a small meatus or a deeper meatus, but it'll always be in the same spot. If you have trouble, you can put lubricant in the urethra. I do that a lot of times. I just will squirt it directly in and then have the catheter follow. And then pull the penis straight and down to the to the knees. So pull it back. Don't pull straight up. Pull down so that the curve is kind of more straight.
Sorry.
No trouble. It's not that bad. The other thing, remember we talked about spinning or twisting. Again, it's a little difficult when you have everything connected. And I don't want to get and I'm not saying that every single catheter you should undo, but if you have trouble getting a catheter in, undo it and then spin it the next time to get it in. Make sure the patient's relaxed, make sure their head's not popping up, have them get a breath. And if they're really tight and they're not relaxing, give them medicine to relax them. If other people have had a tough time doing it and you're coming in, Don't be afraid to give them a pill and wait, 20 minutes or 30 minutes or whatever you have to do, or give them their dose of morphine sooner. That will help them. Remember, a Coudet catheter has a tip like a ski. And like a ski, it's got to be up. You don't spin it, you put it up. Never blow the balloon without urine coming back. Jelly is the most common thing to clog it. You can push on the belly or you can aspirate. If you're ever putting a catheter in for bleeding, it's got to be a 20 French catheter. And realize that the Coudet catheter only has one hole, so that's bad for blood. Beware of CBI, and I think you're going to have a lecture on that. Because with CBI, you can distend the bladder if you don't get the clots out first. If there's any question, get help. And also, the other thing, this is something we don't really get into. If you're going to put a catheter in, ask the patient if they've ever had a catheter before, if they ever had any surgery down there, if they ever had a TURP, if they ever had their prostate out, have they ever had any trouble. And you can do that while you're kind of setting things up. And they might say, yes, I had a catheter, it was really tough. And say, okay, well, I want you just to relax as we're doing it and talk to them as you're doing it. Relax, take it easy, we'll be real gentle, I'm not going to hurt you. Put your head back, relax, breathe, and it'll pop right through and go in. Okay? Any questions?
Under what circumstances, Doctor, would it be possible to put it for
Sorry, 1 second, give me 1 minute. Yeah, Dr. Roberts. Yeah. Yeah. Yeah, catheter's supposed to be out, so we didn't get it out yet? Yeah. Okay, we'll do it that way, that's fine. He's getting anxious, guys, keep him from getting anxious. So let him go home and tell him to come in tomorrow and we'll take the catheter out. Okay, thanks, goodbye. Sorry, I'm sorry, you had a question?
Yeah, under what circumstances would it be contraindicated for a nurse to insert a catheter? Say a patient comes in with bowel surgery and they have an artificial sphincter or...
Oh yeah, okay, so, sphincters, we didn't get into that, but artificial sphincters, if they have an artificial sphincter, you have a cuff there that's blowing up. That's always tight. So you're never going to get a catheter through there, and if you try to put one, you're going to damage it. So an artificial sphincter, you guys should not be putting in, and if the general surgeon or the urologist, whoever it is, missed that, give them a call, because you have to deactivate those. You have to open up that little area, and you have to use a real small catheter, otherwise you damage the sphincter. So that's one thing. If they've had surgeries and had trouble getting catheters in, probably find out first and talk to the doctor on that and say, this guy's had a hypospadias repair, he's had all kinds of trouble. He said he was in the hospital 4 times, or he might tell you that he had a suprapubic tube put in last time, and say they've never been able to get a catheter. So those are things. Don't sit there and say, well, I heard this great lecture from Dr. Roberts, I'm going to go in there, inject jelly, relax it, spin it. You can't do it in those situations. You have to make sure that you're doing what's right. So really difficult things. So that's where you want to take that history and kind of know and kind of go from there. It's a good point bringing up the artificial sphincter. I didn't put that in there. Any other questions? Okay, thank you.
Thank you, Dr. Roberts.